Hello everyone, today we will study about the etiology, classification and the management of the cleft lip and palate. So let's begin with the etiology. The cleft lip and the palate are believed to occur due to the genetic and environmental factors. So let's begin with the heredity. Heredity has long been considered as important etiologic factor for the cleft lip and palate. A study conducted by the Drillin reported that 1 in the 3 children with the cleft had some relatives with similar congenital defects. The clefts of the lip and the palate can be transmitted as a dominant or the recessive trait. The genetic studies have revealed that the definable family history is available in 12 to 20% of the cases. The twin studies demonstrate that the twin sibling of an affected child is also affected in 30 to 50% of the monozygotic twins and 5% of the dizygotic pairs. The transferring growth factor alpha TGFA, transferring growth factor beta 3 TGFB3 and AP2 and MSX1 are the genes that has been identified as having the major role in the development of the cleft lip and the palate. Some of the syndromes associated with the cleft lip and palate are trisomy 13, trisomy 18, cardiofacial syndrome, similarly Gorlin syndrome, orofacial digital syndrome, Treacher-Collins syndrome, van der Waals syndrome, fetal alcohol syndrome, fetal phenytoin syndrome, fetal valporate syndrome. Now next is the environmental factor. The environment factors that can increase the risk of the cleft lip and the palate are divided into the 4 broad categories. They are womb environment, the external environment, the nutrition and the drugs. The teratogens are the certain drugs or the agents that cause the disturbed growth and development in the fetus. These includes the anti-epileptic drugs like the phenytoin, valproic acid, thalidomide, dioxin, pesticide, retinoic acid, maternal alcohol use and the maternal cigarette smoking. Some of the known teratogens are CMVD, that is cortisone, mercaptopurine, methotrexate, Valium and the dilantin and the rubella virus. The infections are the infections such as the RTS, that is rubella, toxoplasmosis and the syphilis. The maternal alcohol use has been related to high rates of the cleft lip and palate. The embryos exposed to the smoking during the first trimester were at increased risk to the having clefts. Now, the multifactorial etiology. Recent studies have shown that the etiology of the cleft lip and palate cannot be attributed solely to either genetic or environmental factor. It seems to involve more than one factor. They argue that unless a person is genetically susceptible, the environmental factors may not by themselves cause the clefts. So for fetus to have the cleft lip and the palate, there must be genital susceptibility for the environmental factor to cause it. Now the predisposing factors like the increased maternal age. Women who conceive late have an increased risk of having an offspring with some form of clefting. The causes remain unknown. Racial. The mongoloid shows the greater percentage of the incidence. Blood supply. Any factors that reduces the blood supply to the nasomaxillary area during the embryological development predisposes to the clefts. Now we'll talk about the classification. The classification, Davies and Reed classification 1922. It is based on the location of the cleft relative to the alveolar process. They are group 1, group 2 and group 3. Group 1 is prealveolar, group 2 postalveolar and group 3 is alveolar clefts. Prealveolar means the clefting involves only the lip and further divided into unilateral, bilateral and median. The group 2 means the postalveolar. It means this group comprises of different degree of hard and soft palate cleft extended up to the alveolaries. Based upon the alveolaries, right? That's why extended up to the alveolaries. Group 3 is alveolar cleft, that is the complete cleft involving the palate, alveolaries and the lip. They are further subdivided into unilateral, bilateral and median. Now next is the views classification in 38. They are group 1, group 2, group 3 and group 4. Group 1, the clefts involving soft palate only. Group 2, cleft involving hard and the soft palate extending up to the incisive foramen. Group 3, they are unilateral but complete. They are complete unilateral cleft involving the soft palate, hard palate, lip and alveolaries. They are the complete but bilateral. affecting the soft palate, hard palate, lips, and the alveoli. The next is Carnahan stripped Y classification. We'll understand it by the picture. So this is the picture. Now this is the block 1, 4, 2, 5, 3, 6. This is the incisive foramen, 7, 8, and 9. So 1 and 4 represents block 1 and 4 represents the lip. Block 2 and 5 represents the alveolus. 3 and 6. This 3 and 6 represents the hard palate, which is anterior to the incisive foramen. 7 and 8 hard palate posterior to incisive foramen. 7 and 8 hard palate posterior to the incisive foramen, and 9 is the soft palate. Now next classification is the Lassell classification according to the Lassell paraphase. Okay, L means lip, A means alveolus, H means hard palate, S means soft palate, H hard palate, A alveolus, and L means lip. The next classification is the classification by the Forg-Anderson. Group 1. They are the clefts of the lip, subdivided into single, double. Single means unilateral or the median, double means bilateral. Group 2. They are the clefts of the lip and palate. They are once again subclassified into single, double. Single means unilateral, double means bilateral. Group 3. They are the cleft of the palate extending up to the incisive. Next, we will talk about the management of the cleft lip and palate. So the treatment is based upon the stage. Stage 1. They comprises of the treatment done from the age of birth to 18 months of the age. Stage 2. From 18 months to 5th year of the life, it is generally corresponds to primary dentition stage. Stage 3. It is the mixed dentition stage. From the age 6 to the 11th year of the life, and stage 4, the permanent dentition stage from the 12 to 18 years. In the stage 1 treatment, it includes the fabrication of the passive obturator, pre-surgical orthopedic, surgical management of the cleft lip, surgical management of the cleft palate. Now, the fabrication of the passive maxillary obturator. The maxillary obturator is the intraoral prosthetic device that fills the palatal cleft and provides the false roofing against which the child can suckle. It reduces the feeding difficulties like the insufficient suction, excessive air intake, and choking. It provides the maxillary cross-arc stability, preventing the arc from collapsing. The clasps can be aid in retention. In case of the insufficient retention, wings made up of the thick wire can be embedded in the acrylic made to follow the cheek contour extraorally. These wings can be stabilized against the cheek by using the micropore or DESI tips. Now next is pre-surgical orthopedics. It includes the NAM, that is the nasoalveolar molding. It is non-surgical method of reshaping the alveolus and the nasolabial complex before the surgery. The aims are to approximate the alveolar segment, and the lips. To approximate, we can see here, approximate the alveolar segment and the lips. See how much gap there was there. Now the gap is closing. See the gap. So that's it. And the next is to correct the malpositioned nasal cartilage, lengthening the deficient columella, decrease the tension in the incision line, and reduce the post-operative scar. It consists of the intraoral molding plate, nasal stents, and the facial stents. Now we have the surgical closure of the lip. Here, the surgical management of the cleft lip. There are many schools of the thought for it. The early school of the thought suggests that the surgery should be performed within 45 days of the birth. According to them, the child soon after the birth shows the marked immunity to the surgical shock. Now, the late school suggests that the surgery should be postponed till the completion of the dentition. They are the reason that the tissue would be able to grow and mature, thereby giving the surgeons more muscle mass to work on. Now, according to Millard, has suggested the rule of 10. The surgery should not be performed less than 10 weeks of the age, when the body weight is not less than 10 pounds and the blood hemoglobin not less than 10 gram percentage. The surgical palate closure. The palatal repair should be attempted between 12 to 24 months of the age. This facilitates the normal speech, hearing, and improves the swallowing. Now, the palatal repair. The bone grafting for the alveolar cleft disorder is divided into the primary and secondary. The primary is done in 1 to 2 years of the age, and the secondary is done in the early 2 to 5 years and late from 11 to 14 years. Here in this, the palatal repair can be accomplished by using the bone transplants that are taken from the rib, iliac bone, mandibular symphysis, tibial bone, or the outer table of the parietal bone. Now, stage 2. The stage 2 comprises of OREO, REO. O for the oral obturator. The adjustment of the intraoral obturator to accommodate the erupting deciduous teeth. E for to maintain a check on the eruption pattern and timing. Again, O for oral hygiene instruction, and R for restoration of the decayed teeth. Similarly, the preventive management. The feeding difficulties are the common problems for the babies with a cleft palate. The specialized feeding bottles such as the Haberman feeder, the Maid Johnson bottle have helped to overcome some of the feeding problems. The parents are educated on importance of the good dental health before the teeth eruption. Similarly, they are given advice regarding the dietary control of the sugar containing food and the drinks. The parents should also understand the value of toothbrushing, and they should use the fluoride not more than 600 parts per million. Now, the next stage is stage 3 treatment. In the stage 3 treatment, the alignment of the anterior teeth, the full orthodontic treatment, expansion and the protraction of the maxilla, and the secondary alveolar bone grafting is done. The secondary alveolar bone grafting has some of the benefits: to provide a firm bony support for the LR base, to minimize the nasal deformity, to eliminate the oronasal and the nasolabial fistula, to stabilization of the maxillary segments, and the facilitation of the teeth eruption into the cleft side. Now, stage 4. The stage 4 consists of the following treatment plans. They are the establishing the occlusion, camouflage of the skeletal discrepancy, evaluate the need of the pre-surgical orthodontics. Now, the camouflage includes the patient is treated using the fixed orthodontic appliance. All the local irregularities like the crowding, spacing, cross-biting, overbite problems are corrected. The hypoplastic maxilla may be given face mask to advance the maxilla. The prosthesis may be given in the case of missing of the teeth after the completion of the orthodontic therapy. Similarly, in the adulthood greater than 18 years, the orthognathic surgery may be indicated. Post-surgical orthodontics and similarly aesthetic surgery may be indicated. Here, most of the cleft lip and the palate patients require the long term of the retention, if not permanent retention, for the following reasons, like that is BTS: B for inadequate bone support, T for absence of the some teeth, and S for presence of the stretched scar tissues. So